Everyone can be seated. Counsel, you will call your next witness.
Dr. Demian Oberbaum.
Raise your right hand. You swear or affirm the testimony you will give to the truth, the whole truth, and nothing but the truth, so help you God?
I do.
Proceed, please, right over here.
Ready to call.
Can you please state your name for the record and please spell your first and last name?
Demian Forrest Obregon. The spelling of the name is Demian. The last name is Obregon.
Where are you currently employed?
University of South Florida.
What is your position at University of South Florida?
I'm a child and adolescent psychiatry fellow.
Can you please tell the jury about your education background?
So I did my undergraduate work at the University of South Florida and then transferred and was in a master's program at Tulane University in pharmacology and then matriculated to the MD PhD program at Tulane University. And then after Katrina hit, I transferred back to the University of South Florida and finished the MD degree. And then after that, I did a general psychiatry residency program, graduated from that, and then started the fellowship, which I'm going to complete in a couple months in child and adolescent psychiatry.
Tell the jury a little bit about your work history and your fellowships that you've been involved with.
Sure. So throughout my education, I have also conducted research in Alzheimer's disease and autism. And so my work history has involved both clinical and medical and basic sciences, as well as clinical care of patients in an inpatient setting, outpatient setting, and other models of care, hospital and different models of care.
Are you required as a psychiatrist to have a license?
Yes.
And are you currently licensed?
Yes, I am.
How long have you had that license?
Since you have a training license that you have to get when you start residency. And so since 2008, I've had definitely a training license. And then after, I want to say 2011, I had a full unrestricted medical license in the state of Florida.
Okay. Tell the jury about the training license. What does that mean?
Training license is a restricted license that requires that a supervising attending physician sign off on basically everything you do.
Now, you said the supervising attending signs off on everything that you do.
That's correct.
Are they present in your sessions?
In some sessions they are, in some sessions they're not. But they are always reviewing in detail, either right after you see the patient or after like a part of the day, what treatment plan you've administered in the details of the care.
When you started to have your training license, where did you begin that part of your work history or education?
That happens in residency.
Okay.
Yeah, internship and residency.
Where was the first location that you had an internship or residency?
That was at the University of South Florida.
Okay. And did that start with your training license in 2008?
That's correct.
Okay. Explain how that program develops when you start there.
Yeah. So you begin at the University of South Florida, and different places have different models of residency education. But at the University of South Florida, you initially start doing rotations either in medicine or pediatrics or both. And a lot of the rotations are hospital work. And so you're working in a team, rounding on patients in an inpatient setting typically. And then it progresses to inpatient psychiatry. So like a psychiatric unit. And then after that time, in the second and third years, you start transitioning to outpatient psychiatry and seeing patients in the outpatient setting. And then your fourth year is largely electives, or, kind of filled up with combinations of either inpatient, consult, or other hospitalist work, depending on your interests.
Did you complete that portion of what you were required to do to obtain your license?
Yes.
Okay. And when you began at USF, what was the first rotation that you were involved with?
I believe that was Tampa General. It was either Tampa General inpatient medicine or it was at the VA hospital inpatient medicine, one of the two.
Do you remember how long that lasted?
The rotations are typically month long, but sometimes you have to do multiple rotations, so they can stretch on for 2 or 3 months at times.
When did you first start seeing patients on an outpatient basis?
So in medical school, you see patients on an outpatient basis, again, kind of with a resident or an intern and an attending. And so I guess in medical school, we started seeing patients in a supervised fashion. And then in the third year of residency was more of the outpatient year. And so that's where more of the outpatient experience started.
When you were involved with the USF program, do you remember what year it was that you started seeing outpatients?
For residency?
Yes.
So that would have been my third year of training.
Do you remember what calendar year that was?
I think it was probably the 2010-2011 year.
Okay. When would that have began, do you know?
July 1st.
Okay. So July 1st, 2010,
I believe so.
that's when your outpatient began?
Mm-hmm.
Yes?
I believe so.
Okay. Tell me how you end up getting patients, how you get assigned patients.
So it's typically done where a attending and a resident, attending oftentimes has followed the same patients for multiple years, and the resident will oftentimes either follow the same group of patients for 1 and some of the patients for 2 years, and then so-called handoff patients from one resident to the next resident that is coming in for the third year, for example. Okay. And so during that time, the residents meet and or the attendings and go over different aspects of the care of the patients.
Do you have any choice in which patients you're assigned?
No.
Okay.
Not often.
When you're initially assigned a patient, what information do you receive?
So we have an electronic medical record. So you receive notes from the care at the University of South Florida, for example, and you often go over salient aspects of diagnosis, treatment course, and kind of future directions, like where the treatment would head if, for example, something didn't work out.
What does that mean to a layman?
Oh, thank you. So to explain, it is diagnosis, basically the impression of the underlying medical reason or psychiatric reason of a person having problems with mood or having problems with misperceptions, and then what the plan is for treating this person, either with medications or psychotherapeutic interventions such as counseling or other interventions.
The patients that you have are psychiatric patients.
That's correct.
Okay, you're not treating someone for a medical issue like a broken bone or something of that nature.
That's correct.
Okay. Tell me about your hours, how many days you work and seeing the patients, how long that is.
So, again, we have 4 regular days where our days start at 8 and then end 5 or 6, or depending on when, some patient care responsibilities run over or documentation responsibilities run over. And then one of the days is set aside for didactics or learning in the morning, and then we have patient care in the afternoon.
What are didactics?
So didactics are just resident education, basically.
Okay, so that's not dealing with patients.
We'll go over cases, but not specific cases, I guess you could say. They're de-identified, and oftentimes it's more kind of the psychopharmacology or psychotherapeutic interventions or the interface between medicine and psychiatry.
When you are seeing an individual patient, how long are those sessions?
They vary, so the initial evaluations can vary between 45 minutes and up to 3 hours. But typically 1 hour. And then some time for discussion with the attending physician. And then the attending and the resident or intern will come back and interview the patient together and talk about implications and do psychoeducation about our impression and treatment plan. And then during follow-up appointments, it's half an hour, but it's not restricted. So if there's an emergency or there's something that comes up that needs to be addressed, then sometimes they'll run over that half an hour time slot.
When a patient is being handed from one resident to another, do you conduct a brand new initial assessment since you would be taking over that case new?
Oftentimes, yeah. So we even though it's not a new patient to the clinic, we would set an hour time slot and then do more of an extensive evaluation than we do for the follow-up evaluations typically, yes.
Do you have access to the records from the prior resident?
Oftentimes.
Okay. Is there ever a time when you do not have that?
So if it's somewhere where we haven't gained access to records from a different institution because those are not authorized by the patient or for some other logistic reason, or logistically if the electronic medical record is not up to par, then at times we can't get those records, but that's very rare.
Okay, so it's rare that you would not have all the records.
Actually, it's more common that we would not have all the records from other providers or mental health therapists, okay. Because often when we do request records, they only send partial records.
Okay. As far as records, if you're getting a patient that was already being seen at University of South Florida, mm-hmm. do you have any problems accessing the records internally if they have been seen by someone at USF?
Not typically.
Okay. So if a patient goes from one resident to another, are those records have any problem transferring?
Not typically.
Okay.
Yeah.
And you said you began seeing patients, outpatient, in this setting back in July of 2010?
So we see outpatients in medical school, and then there's some experiences during the first 2 years where we do see outpatients, but the third year for my training was all outpatients for the whole year, basically.
I'm just talking about at USF.
Yeah.
That began for you back in July of 2010?
Yes.
Okay. Was there a time when you ended up treating a patient by the name of Julie Schenecker?
Yes.
And do you see Ms. Schenecker in the courtroom?
Yes.
Can you identify her and state an article of clothing that she's wearing?
She's wearing a black jacket and glasses.
The record would reflect that the witnesses identified the defendant.
Yes.
Tell me when you first became involved with treating Ms. Schenecker.
Looking back at my notes, it looks like July 20th.
July 20th of what year?
2010.
Okay. So July 20th of 2010 was the first time that you had any contact with Ms. Schenecker?
That's correct.
Okay. Tell me how she specifically ended up being your patient.
She was transferred from one resident to another resident, to me.
Does that mean that she was already receiving treatment at University of South Florida?
Yes.
Okay. So this is was it a situation where it's transferred from one resident, as you explained earlier, to another?
That's correct.
Who was the prior resident, if you're aware, for Ms. Schenecker prior to you treating her?
Dr. Gabriel White.
Now, you testified earlier about sometimes the attending psychiatrist will maintain contact with the same patient for a period of time. What was the case of the attending psychiatrist in regards to Ms. Schenecker as your patient?
So to my understanding, Dr. Isis Marrero had followed Mrs. Schenecker prior to me coming into her care.
And back in July of 2010, this is when you're first starting to see patients in this setting?
Yes.
Okay. When you initially see Ms. Schenecker back in July, on July 20th of 2010, can you tell me how long that session was?
20 minutes of face-to-face time, and then several minutes of time with the attending. So we'll discuss the case and kind of go back over certain aspects of the care. So I'm not sure exactly how much time we spent that day.
Okay. Do you annotate in your records the amount of time that you're with your patient?
Yes.
Okay. And for this record, on July 20th of 2010, how much time is annotated that you were with Ms. Schenecker on that date?
20 minutes.
Now, when you were talking about earlier that sometimes when you get assigned a patient, you may do a more lengthy appointment for your first appointment. Was this your first appointment with Ms. Schenecker?
To my understanding.
Okay. And did you have any information about Ms. Schenecker's condition or the progress of her treatment that happened prior to you treating her?
Yes.
And is that something that you would normally rely on as part of what your position is as a psychiatrist?
Yes.
You normally rely on other records, prior treating records?
Integrated. So integrated with my own impressions and own diagnostic. But yeah, we would utilize that information.
What information did you have when you first encountered Ms. Schenecker about her diagnosis?
So Dr. White had given me a summary of her care. Up until that point, I'm not 100% sure on the details this far out, but one of the aspects was that she had a personality disorder.
What was her mental health diagnosis as far as you treating her?
Just referring back to my notes. Bipolar 1 disorder, alcohol abuse, pathological gambling, and then cluster B traits.
Okay. So you indicate in your narrative back on July 20th of 2010 that there's a history, was there a history of bipolar 1 disorder?
Yes.
Okay. Can you explain to the jury what bipolar 1 disorder means?
So bipolar 1 disorder has specific criteria that are required to make that diagnosis involving a manic episode. So you have to have a full-blown manic episode in your history at some point where you either have irritable or grandiose mood, you have, and then you have to have several other criteria. Could be excessive energy, erratic behavior, risk-taking behavior, and several other criteria.
Okay. Is there also a depression side to a bipolar 1 diagnosis?
There doesn't have to be, but frequently, more often there is than not, for sure.
When you have information, or in this case, did you have information that there were additional things going on other than the bipolar 1 disorder?
Yes.
Okay. As far as a mental health diagnosis goes, are there characteristics or requirements in order to diagnose someone with a certain mental illness?
Yes.
Okay. And are there times when it may be fluid, where somebody may meet the criteria for one or more diagnosis?
Can you elaborate on what you're asking?
Okay. For your indication with Ms. Schenecker when you first encountered her in July 20th of 2010, is there an indication in your record that it's bipolar 1 disorder with psychotic features versus a schizoaffective disorder, bipolar type? And I'm referring to the first line of your narrative, the first paragraph.
So, yes. There's very little difference between those two diagnoses.
Okay.
So the schizoaffective disorder requires psychotic, which is problems with thought, a disorder of thought, when you don't have, in the absence of significant affective symptoms, so a depression or a mania, for example. And the bipolar 1 diagnosis, you wouldn't have that. Whenever you had psychotic features, it would be in the presence of either a severe depression or a manic episode. So they're very similar, and sometimes history is unclear, and so that's where that reference points to.
Okay. Where it may be either or.
Mm-hmm.
Is that yes?
That's correct.
Okay. Now, is bipolar 1 a mood disorder or a thought disorder?
It is. It's more than just that. So, bipolar type 1 is a mood disorder, but it can affect thought.
Okay. And in this case, did Ms. Schenecker have a history of also having a thought disorder?
Yes.
Okay. Is that the reason why there's a diagnosis of not only bipolar 1, but the psychotic features?
Correct.
Are the psychotic features a reflection of a thought disorder?
Correct.
Okay. Is schizoaffective disorder a thought disorder and a mood disorder?
Correct.
Okay. Was your diagnosis of Ms. Schenecker consistently bipolar 1 disorder with psychotic features?
To my understanding.
Okay.
Yeah.
Now, as part of your evaluation, you look at the patient as a whole?
Yes.
Okay. Are there times when, along with their mental health diagnosis, you're also addressing other issues that are going on with that patient?
Yes.
Okay. How is that reflected in a diagnosis as far as the axis?
So the Axis 1 indications or disorders are the primary mental health or psychiatric diagnoses, whereas Axis 2, and this has all changed recently with DSM-5, but in DSM-4, which the system is applicable to this date when I first encountered Mrs. Schenecker, Axis 2 is reserved for intellectual disability and personality disorders or personality traits. And Axis 3 is reserved for medical issues, so-called medical issues, that are not psychiatric, that have an impact or a bearing on the psychiatric diagnoses. And then Axis 4 is reserved for psychosocial factors, so stress in someone's life, that are having an impact on the diagnoses or exacerbating symptoms. And Axis 5 is a global assessment of functioning, which gives a kind of a numeric indication of the person's overall functioning globally.
When you first saw Ms. Schenecker back on July 20th, 2010, what was your Axis 4 diagnosis?
Chronic mental illness.
Okay. And the Axis 4 shows what in your diagnosis? What does that tell someone?
So there are social impacts of chronic mental illness. So it basically kind of communicates that that there are impacts in this person's life that may exacerbate symptoms related to just having chronic mental illness.
Okay. You talked a little bit earlier about a personality disorder. In your initial evaluation or visit with Ms. Schenecker back on July 20th, 2010, do you state in the records a borderline personality disorder?
No, I don't think that's stated.
All right. When you saw Ms. Schenecker back on July 20th, 2010, was she having any physical symptoms at that time?
Let me refer back to my notes, if you don't mind. Yes.
What physical symptoms was she having at that time?
She was having, to my understanding, mild lip smacking.
Okay. What was that from?
The chronic, to my understanding, in her situation, it was due to her taking antipsychotic medication for the thought component of the mood disorder. It sounds pretty complicated. And at some point, when she experienced that, which can be a side effect of the medication, she stopped the medication, which unfortunately makes it worse if someone just stops it rather than slowly tapers it. And so then she had the chronic side effect basically, which is termed tardive dyskinesia.
The tardive dyskinesia, can you explain to the jury what that is?
So the antipsychotics act on the part of the brain that not only helps us differentiate between our internal environment and external environment, what's in our mind and what's in our environment, but it also acts on a part of the brain that's responsible for movement. This part of the brain is often impacted in Parkinson's, and so if someone is on either too high of a dose or unfortunately it can just be a chronic effect of being on the medication for a long period of time, then they can develop movement issues as a side effect of being on this medication, on antipsychotic medications.
How does that manifest itself with a patient?
In a variety of ways, but typically tongue movements where the patient has difficulty keeping their tongue in their mouth, and so they could feel like an urge to kind of push it out of their mouth, or at times it's unconscious. And then when we were using the older generations of antipsychotics years ago, we still use them sometimes in very refractory cases. We saw more of the neck and truncal movements,
What is a truncal movement?
Where the trunk of someone's body moves uncontrollably.
That mean the torso area? Mm-hmm. Yes?
That's correct, yeah.
Okay. Well, how did that manifest itself with Ms. Schenecker? What did she tell you about her symptoms of tardive dyskinesia?
I don't remember at that time what she told me exactly, but on
You can
exam.
refer to your records if you need to.
Yeah. Yeah, so in the notes it indicates lip smacking, kind of sucking movements, and leg jerks at night.
Was there any indication of problems sleeping based on the leg jerking?
Yes.
What did she tell you about that?
As indicated in my notes, 2 to 4 beers per week with friends and family.
And was that something that you recommended with the medication that she was taking?
No.
Okay. When you see a patient, do you conduct what's called a mental status exam?
Yes.
Tell the jury about that.
So a mental status exam covers multiple aspects of how somebody is presenting themselves and how they're thinking. It can be more comprehensive, but a basic mental status exam comments on appearance, behavior, comments on their stated mood, their assessment of their ability to tell you where they're at, their orientation, the way that they're thinking, and then generalizations about what they're thinking, and then their judgments of their ability to understand their condition and make proper decisions.
What was Ms. Schenecker's mood back on July 20th of 2010?
Okay. So the mood is what the patient reports, and the affect, which is another part of the mental status exam, is what the evaluator observes.
Your observations
Correct.
when you're speaking to the patient.
That's correct.
Okay. And in this case, back in July, on July 20th, 2010, you spoke to her for 20 minutes?
That's correct.
Okay. When you do your overall visual of Miss Schenecker, what did you observe about her eye contact at that time?
So that eye contact is listed as good.
Did Ms. Schenecker, back on that date, on July 20, 2010, express to you any concerns about insomnia or sleeping?
Yes.
Was that related to the leg jerking?
Yes.
Okay. When you see the patient, in this case, Ms. Schenecker, back on July 20, 2010, you have to staff that with the attending psychiatrist as well?
Correct.
Now, is that done at the same time while the patient is still there?
It varies. So it can be, but at times it's done at the end of like a half day. But when you're starting third year, it is closer supervision. So when you're starting the outpatient year, as I was at this time, it's closer supervision. So typically the patient will either still be there or had just left.
As a psychiatrist, are you able to prescribe medication?
Yes.
Now, do you prescribe medication to every patient that you see?
No.
Does that depend on what the person's diagnosis is, or?
It's multifactorial.
Okay. And is that something that you review with the attending physician as well, what medications you may be prescribing someone?
Correct.
In this case with Ms. Schenecker, was she a patient that had a history of taking medication?
Correct.
Did you have any opinion about her tardive dyskinesia symptoms, whether they were something that was brought on by a medication that was just taken, or if it was a symptom of continued antipsychotic drug prescription, or that she was prescribed that?
From the information gathered from the resident and attending prior to me, it was largely due to experiencing kind of the first symptoms, and then from her suddenly stopping the medication.
Okay. Is there a time, have there been times where a patient maybe thinks they need to stop a medication, and then in the end it ends up making their symptoms worse?
Yes.
Okay. And are there times when patients are advised, if they are having reactions to medications, to discontinue or to slow down taking those medications?
Yes.
Now, you also have a background in pharmacology as well?
Correct.
And are there different side effects for different people for the same medication?
Yes.
Okay. When you saw Ms. Schenecker on July 20th, 2010, does she leave your visit with prescriptions for medications that you're prescribing her?
So that's not indicated directly here. It's in a separate part of our electronic medical record. But oftentimes when it's indicated in the medical record as continue or increase or change, oftentimes they will. But that information is not provided here.
In your record, is there an indication under plan for medications?
Yes.
And are those the medications that Ms. Schenecker would have been prescribed or advised to continue to take?
Yes.
Okay. What were the medications that she was prescribed or continuing to take back in July 20th, 2010?
So Lamictal, trazodone, Cogentin, And I believe that's it.
Okay. What is Lamictal for?
Lamictal is an anticonvulsant medication that is used for mood stabilization
Okay.
for bipolar disorder.
So the Lamictal is for mood stabilization.
That's correct.
Okay. And is there an indication that if there's a side effect to stop or to seek attention in what you have on the medication plan?
Yes.
Okay. Is there an indication if you get a rash to cease taking it or seek medical attention?
Yes.
Okay. So it's not unusual to give someone an advisory like that about a medication?
Exactly.
Okay. The trazodone, what is that for?
That's for sleep. But it's also at times used for depression.
The cogentin, what is that for?
That is to assist with the tardive dyskinesia.
And then you have an indication, I guess, just thoughts of maybe future medications if what you're giving her doesn't work.
Correct.
Is that an unusual thing to change or alter a patient's medication based on how they're responding to it?
No.
When is the next time you had any contact with Ms. Schenecker?
It looks like there was a phone call on July 23rd of 2010.
What was the basis of that phone call 3 days later?
Leg jerking complaints from Mrs. Schenecker.
The leg jerking continuing to be a problem?
Correct.
Okay. And did you alter her medication at all based on that?
Yes.
How did you do that?
We added Buspirone or Buspar at that time.
So was there an indication previously on July 20th that that may be an avenue that you would take if the other medication wasn't working?
Correct.
Okay. And so based on her call, did you add that?
Correct.
What is the next office visit that you had with Ms. Schenecker?
Based on the record, August 3rd, 2010,
How long was that visit with Ms. Schenecker?
20 minutes.
Now, during this visit on August 3rd, is Dr. Marrero with you or the supervising attending psychiatrist?
In the room is what you're asking?
Yes.
Most likely not.
Okay. So most likely it's something that you discuss after the visit?
Correct.
Okay. How was Ms. Schenecker doing on August 3rd, 2010?
Not too much different, really, from the prior evaluation.
Was she expressing any depressive symptoms at that time?
Yes.
What did she tell you about that, or what do you have indicated about her depressive symptoms?
Some mild depressed mood and decrease in appetite.
Okay. What do you do when a patient that has a history of bipolar 1 with psychotic features comes in and tells you that they're starting to have mild depressive symptoms?
That's multifactorial because it depends. If there's a reversible stressor in their life, you may address that. If there is no identifiable stressor, you may change medications or other interventions, start counseling, or increase the care, either psychiatric care or counseling care.
Do you do an inquiry about their feelings at that time?
Yes.
What do you ask them about helplessness, hopelessness, things like that?
So conversationally asking, and again, I'm not exactly sure, because I don't have a transcript of our discussions there, but generally polling for different symptoms. How's your mood? How has your activity level been? What have you been doing? To see if they're following their interests and things they desire to do, and then asking about their outlook and what they're planning on doing and how they feel as far as their ability to affect and make their life better, for kind of, again, indirectly asking for regarding helplessness and hopelessness.
Okay, so when you have an indication of denies feelings of helplessness, hopelessness, things like that, are you asking a patient, are you helpless, are you hopeless?
It may not be a direct question.
Okay.
It may be an indirect question. Sometimes it is that very direct question.
What does that tell you as a psychiatrist if somebody is having those feelings?
Worsening symptoms.
Okay.
Or more severe symptoms.
So on this day back in August of 2010, August 3rd of 2010, there was no indication of feelings of helplessness or hopelessness.
Not that I see indicated in the record.
Okay. Now, when you're speaking to an individual such as, or Ms. Schenecker specifically, who has the mental health history that she does, the brain illness that she does, are you continuously speaking to her about suicidal thoughts, suicidal ideations every time that you speak with her?
Yes.
Does that include your phone conversations with her?
Many times.
Okay.
Yeah.
So that's a standard questioning that you do?
Yeah.
Does it become almost, or is it routine?
Yeah.
On your mental status exam, what was your note, or what do you remember about her eye contact, or your indication about her eye contact?
Intense eye contact.
Now, is that a change from your prior assessment regarding her eye contact?
It is.
What does that mean?
So when you evaluate, each time you'll gain, hopefully gain more information about the patient that you're taking care of in an effort to, again, come to a better understanding of the patient and their treatment and their need for treatment. And so sometimes you pick up on things you hadn't before. So the change may just mean observation, whereas good eye contact could be someone is very attentive, I'm looking at the jury at this point, and making good eye contact versus kind of, the eye contact where it's not as engaging. Intense eye contact may be little movement and more kind of staring at the evaluator, for example.
Okay. Would that be like a blank stare?
No.
Okay.
No.
Just a little bit different than intense,
Than merely good.
than good eye contact.
Yeah. Yep.
Okay. Enough that you've noted it.
Correct.
Okay. What medications were continued or changed on August 3rd, 2010?
So Lamictal was continued, and Cogentin was continued. Buspar was discontinued, and Trazodone was discontinued, and clonazepam was continued at that time.
Do you mean Klonopin?
Yes.
Okay. What was the Klonopin for?
In her case, it was for leg jerks and the tardive dyskinesia symptoms.
Okay. Now, when a patient is experiencing symptoms of tardive dyskinesia, are they able to control those leg movements or physical movements?
Often, no.
When is the next time that you see Ms. Schenecker?
According to the record, August 10th.
Okay. How long did you meet with Ms. Schenecker back on August 10th of 2010?
According to the record, 20 minutes.
Okay. Now, she's seeing you now a week later. Is she seeing you on a weekly basis?
I don't recall, actually, if that was... Actually, it looks like the plan for follow-up was closer follow-up, yes. I don't know if it's a weekly basis. Probably like 1 to 2 weeks would be kind of the close follow-up.
Okay. So normally a patient would see you either once every week or once every 2 weeks?
No,
Okay. How often would a patient normally see you?
it's highly variable,
Okay. So it just depends.
yes.
In this case, was there any indication up to this point on August 10th of 2010 that she had ever missed any appointments?
I can't answer, I'm not sure.
If she missed an appointment, would that be included in the...
Our medical record.
Okay. And I believe you testified that on August 10th, 2010, you saw her on that date for 20 minutes?
That's correct.
Okay. How were her depressive symptoms at that point?
I believe they were still in the mild range, according to my note, but slightly worse than on the evaluation before.
Okay. So she has continued mild depressive symptoms, but you believe that they were a little bit worse than the week before?
That's correct.
Okay. And once again, you go over the same kind of questions about helplessness, hopelessness, suicide ideation, things of that nature.
That's correct.
And there were no indications at that point that any of those things were an issue at that on that date.
According to the medical record.
Okay. As far as your mental status exam, how's her eye contact then?
Continues to be listed as intense eye contact.
Now, in this record, you have a listing of suicide risk assessment.
That's correct.
Can you explain to the jury how you go through that?
So the suicide risk assessment involves both historic factors, aspects of the mental status exam, so what the psychiatrist is observing, in addition to have they ever attempted suicide in the past, have they attempted self-harm that's non-suicidal in nature, if they had psychotic thought processes in the past or currently, if they had problems with mood currently or in the past, aspects involving risk factors such as age, and
I'm sorry, what did you say? Risk factors such as?
such as age.
How does that affect someone's suicide risk?
If they're younger or older, it tends to slightly increase the risk of suicide. So patients above 65 or younger, yeah, than 20.
Okay, I was gonna ask you what was older, but it's 65.
Well, yeah.
Okay.
Yeah.
All right, go ahead, I'm sorry.
And whether or not they're impulsive, and so it gives a more kind of directed and summarized version of the suicide risk factors rather than the narrative version that may be in other aspects of the note.
And in Ms. Schenecker's case specifically, do you speak to her about her religious thoughts about suicide, or?
Yes.
How does that manifest itself? How's that question posed to a patient about religious prohibition?
It can, again, I don't know how I posed it at that time, but it can involve asking someone, does their value system or spiritual system or religious value system prohibit one from committing suicide?
And she indicated to you that she believed in a religious prohibition to suicide.
According to the medical record, yes.
Okay. How were her symptoms at that juncture for her tardive dyskinesia?
They were better with the initiation of the clonazepam or the Klonopin.
Okay. And the Klonopin replaced the boost bar that you had before?
That's correct.
Okay. And so it seemed that her tardive dyskinesia symptoms, were they improving?
That's correct.
Okay. Are tardive dyskinesia symptoms that can fluctuate?
Yes.
Okay. Is that unusual?
No.
Tell me about the medication that was continued or prescribed back on August 10th of 2010.
So Lamictal was continued, Congentin was continued, clonazepam or Klonopin was continued, and venlafaxine was started or initiated
Now, why was that added at that time?
because of the worsening of the depressive symptoms.
Okay. Anything else that was added or continued? As far as medication?
Not that I see here. Was it Cogentin possibly continued? Cogentin, I don't know if I mentioned that.
Okay.
Cogentin was continued at a decreased dose.
Okay, you decreased the Cogentin but continued it.
That's right.
So sometimes when you're continuing a medication, you still may alter the dose, either more or less.
That's correct.
Okay. Is that unusual with treating someone?
No.
No? Okay. Do you receive a phone call from Ms. Schenecker after that August 10th date?
That's correct.
Tell me when you received that phone call.
It's indicated as August 20th, 2010.
What was the basis of that phone call?
According to the medical record, Mrs. Schenecker requested to increase the Effexor from 37.5 to 75 milligrams.
Okay. How much of an increase is that?
It's a 100% increase.
Okay. And what does the Effexor treat?
Depressive symptoms and anxiety, but depressive symptoms more so in this case.
The request to increase the dosage of Effexor, What was your opinion at that point of increasing that dose?
It's something that's typically done, so I was fully positively aware and okay with that increase.
Does that give you any indication about how Ms. Schenecker was doing at that juncture on August 20th, 2010 with her depressive symptoms?
It's not indicated here, unfortunately, but at times, if it begins to work, then, but it's not fully treating patient symptoms, and I'm speaking in general, not in this case, because there's no indication here, unfortunately. At times they'll want to increase prior to coming back, and if it's within the normal titration or increased schedule or very close to it, then oftentimes psychiatrists are in agreement, like I was in this case. But at times, it's because it's not working, and patients would like it to work faster. It's not always the case that raising a medication will make it work faster.
Okay. When you add a medication to treat things like depressive symptoms, is there a time frame before that medication begins to take effect or relieve symptoms?
Yeah, it's highly variable. So the common belief in our field is that for the treatment of depression, you really need 4 weeks to obtain the effects. However, in studies of some of the antidepressants, as early as 24 hours, even double-blinded placebo randomized controlled trials where the placebo effect, the so-called placebo effect, has been controlled for. There are some oftentimes observable improvements in information processing, specifically of faces, that are observed even after 24 hours. So again, it's very highly variable, and it's really on a case-by-case basis.
Okay.
But again, the general consensus agreement is really about 4 weeks for depressive symptoms.
Okay, so generally 4 weeks, but sometimes could be quickly.
That's correct. 24
hours. In this case, when you receive the phone call, what is your opinion about Ms. Schenecker's depressive symptoms at that time?
Mild to moderate depressive symptoms.
And is that the first time that you're indicating that they're not only mild, but mild to moderate because they're continued?
Don't necessarily think it's continued. It's not so much the time course, but the severity that I'm indicating there.
Okay, so
but yes, that's a first occurrence.
The depressive symptoms, in your opinion, at that time are getting more severe?
That's what's indicated in the record.
Okay. So you were okay at that point with increasing her dosage?
That's correct.
Was there another phone call received on the 24th?
That's correct.
August 24, 2010?
Yes.
Tell me about that phone call.
She called regarding increased perioral movements associated with tardive dyskinesia. And
What is perioral?
around the mouth. So kind of the sucking and lip smacking movements.
Was that something that she had already indicated to you in the past?
Correct.
Or how tardive dyskinesia manifested itself with her?
Correct.
Okay. And what does she tell you about her tardive dyskinesia at that juncture?
It appeared to have an exacerbation during that time.
Okay. Once again, is that unusual for the symptoms to get worse at times and get better at times?
No.
Did you change or add medication based on her increased mouth movements?
Yes.
What did you do?
Slightly increase the cogentin.
Okay. From 1 milligram to 1.5 milligram?
Twice a day. That's correct.
When is the next time that you saw Ms. Schenecker?
On August 27th, according to the record.
How long did you see Ms. Schenecker on August 27th of 2010?
For 20 minutes.
Tell me how her depressive symptoms were at that time.
Mild depressive symptoms are indicated.
So they're continued again in this visit?
Yes.
Okay. The tardive dyskinesia symptoms, how were they at the time when you observed her and spoke to her on August 27, 2010?
It appears the record indicates that they were similar to the phone call prior to the evaluation.
Okay. What did she tell you about them?
She indicates that she continued to have the feeling of wanting to push her tongue out of her mouth.
Is that unusual for tardive dyskinesia symptoms?
No.
Okay, that's what you explained earlier, what a patient's feelings are regarding their tongue?
That's correct.
Okay. What did you observe back on August 27, 2010 on the mental statics exam regarding her eye contact?
Intense eye contact.
Did you change her medication or continue her medication in any way on August 27th?
Yes. We started a taper and discontinuation of venlafaxine at that time.
What was the venlafaxine for?
Depressive symptoms.
Okay. Why at that juncture were you tapering or discontinuing her medication for depression?
It appeared that the venlafaxine was associated with worsening of the tardive dyskinesia symptoms of the tongue protrusion.
Did you replace that medication with something else to manage her depressive episodes or depressive symptoms at that time?
That medication was not replaced at that time. However, lamotrigine is also indicated for bipolar depression, or the Lamictal.
Okay. So she was continuing with the Lamictal.
That's correct.
And the Lamictal was for?
Mood stabilization, but it also has an indication for depressive episodes in bipolar disorder, if that makes sense.
Okay. What is the difference between previously having her on the Lamictal for the mood stabilization and in addition giving her medication for depression to now just having her have the Lamictal?
So, I guess augmentation of the antidepressant effect of the lamotrigine versus just having the lamotrigine or the Lamictal given.
Do you increase that medication in any way to make up for not giving her the venlafaxine?
No.
Okay. And is there a reason why the venlafaxine was not replaced with another antidepressant at that time?
Yes. And again, I don't know that it's 100% indicated in the medical record here, but in general, if there is a side effect, we like to do one thing at a time so we know what's responsible for the side effect. So if we think that venlafaxine was causing worsening tongue protrusion, then we will get rid of the venlafaxine or taper it down slowly and carefully, and then observe and see if the tongue protrusion improves.
Okay, so you're isolating that medication to see if it's causing the side effects?
Yes, and so if we would replace the venlafaxine, and there was a different side effect, we wouldn't know which agent was responsible for that side effect.
Was there any other medication continued other than the Lamictal?
The Cogentin, the Klonopin, and I believe that's it according to the medical record.
Now, these times that you're seeing Ms. Schenecker in July and August, you're continuing to staff the case with a supervisor or a
Yeah, for every
psychiatrist?
case,
Okay.
for every time I see her.
Do you ever have an indication or an independent recollection of a supervising psychiatrist coming in and being present for the sessions that you had with Ms. Schenecker?
I can't recall.
Okay. When is the next time that you speak with Ms. Schenecker and have a session with her?
I believe it's September 7th, 2010, according to the medical record.
How long do you speak to Ms. Schenecker on that day?
20 minutes.
Tell me about her depressive symptoms on that day, on September 7th of 2010.
Mild to moderate symptoms.
Is that combined with affecting her energy level in any way?
Yes.
What does she tell you about that?
Lack of energy.
When she has, are you doing any of these sessions by phone, or is she physically coming in?
The phone sessions will be indicated by return of phone call, or
Okay.
most of the sessions are, if it's with a mental status exam, then it's face-to-face.
Okay.
Yeah,
So these
but-
sessions are face-to-face?
Yes, but sometimes like information from a phone call will be incorporated in part of the history of present illness section.
Okay. How is her eye contact on your mental status exam at that time?
Intense eye contact.
Are you continuing during these sessions that are ongoing in August and beginning in September to go over the suicide risk assessment with her?
Yes.
And is she answering all of those questions?
So it's, when you say answering all those questions, it's not as structured as that. It's more of information gathering during routine symptom checking.
Okay.
Versus like a structured form that I give her, for example.
Okay. And all of these things, as far as talking to her about how she's doing, prescribing medication, talking to her about side effects of that, and doing your mental status exam, and speaking to your supervisor, these things are happening within that 20-minute time frame?
No.
Okay. So just speaking to her is happening within the 20-minute time frame?
Correct. And at times, although it's not indicated in the electronic medical record, at times, to my recollection, we would run over that 20-minute time period, but that is kind of definitely designated as face-to-face time with Mrs. Schenecker.
Okay. Tell me about the medication that is changed or continued on September 7th, 2010.
So lamotrigine was continued, Cogentin was continued, clonazepam was continued. Is one of two medications that have been shown to reduce suicidality. The other being Clozaril, which is a so-called atypical antipsychotic with lots of monitoring requirements, and lithium is a first-line treatment for bipolar disorder, but it's also used for depression and bipolar depression to augment or to even replace something like lamotrigine, something that may not be effective in controlling depressive symptoms.
Miss Schenecker's illness is the bipolar 1 with psychotic features. Is the medication to address the mood symptoms as well as the thought disorder?
It's a good question. I think that's controversial in the field of psychiatry, but I would say the expert opinion in our field would be yes. If you're treating someone with bipolar disorder type 1, if the mood is stabilized and improved, then the thought will be stabilized and improved. But that's not how every patient with psychotic features and bipolar 1 disorder are treated.
Okay.
Sometimes they'll use antipsychotics. The problem with using antipsychotics in a patient with tardive dyskinesia is that it can exacerbate tardive dyskinesia and worsen stressors on a patient because there are social implications and sleep implications of having worsening tardive dyskinesia symptoms.
Is sleep, stressors, things like that, are those factors that affect someone with bipolar disorder's mood?
Absolutely.
Okay. When you have someone who has differing diagnosis or kind of on the scale of bipolar 1 with psychotic features, maybe going into schizoaffective disorder, bipolar type, meaning that there's a thought disorder for schizoaffective, a thought disorder that is independent of the mood disorder. Do you have to treat those separately with medication if they're independent of each other?
At times.
Okay. The lithium that is prescribed to Ms. Schenecker on September 7th of 2010, tell me about how long that takes to regulate in someone's system or to take effect.
It's variable. It can be as much as 2 or 3 weeks, or even longer at times. But oftentimes a steady state or kind of a stable blood level of the medication is reached within 3 to 5 days.
Is that something that is called therapeutic levels?
Yes.
Okay. Explain to the jury what a therapeutic level means.
Therapeutic level is a level at which a majority or expected number of patients will have an effect from the medication.
How do you determine if a patient has reached a therapeutic level for that medication?
Most medications are determined to be at a therapeutic level just based on the dose. Other medications are determined to be at a therapeutic level, like lithium, at times with blood tests.
Did you ever request or confirm through blood tests what Ms. Schenecker's therapeutic level was for the lithium?
I'll have to consult the medical, most likely, because it's kind of standard of care.
How long before you would do something like that? Have someone's blood drawn to test for therapeutic level?
In an outpatient setting, within a couple weeks.
Okay.
Yeah. So it's not indicated. I don't see it indicated here in the medical record.
That any blood work was ordered to determine if she'd reached therapeutic levels?
So there's a note, we'll follow up with Brandon McDill Clinic where her labs were drawn. So it was ordered and due to be followed up on, but there's something missing here as far as, it being ordered. And it could have been a prescription pad, or it was written on a prescription pad and given to Mrs. Schenecker.
When was the next time that you had a session with Ms. Schenecker after September 7th?
According to the medical record, September 28th.
Do you have any indication about September 14th, 2010?
Yes, sorry.
Okay. How long did you meet with Ms. Schenecker on September 14th, 2010?
At least 20 minutes.
Okay. How was she doing as far as her depressive symptoms at that time?
Her depressive symptoms were mild at that time and seemed to have improved.
Okay. So there's an indication that her mood has improved some, but still mild depression?
Correct.
Okay. Is there anything else that she's indicating to you at that time as far as her depression or energy, things of that nature?
Continued lack of energy.
Does she talk to you about irritability?
Yes, mild irritability.
What does that mean as far as someone's depressive symptoms that has a mood disorder?
Somebody with mild irritability may have lower tolerance for frustration.
What do you note about her mental status exam and her eye contact?
Continued intense eye contact.
Okay. So the first time you see her, she has good eye contact, and then after that it's intense eye contact?
Again, it's ongoing observations, and hindsight's 20/20, so I think she always had intense eye contact.
Okay. So you believe that was probably always the case?
Yes.
Okay. Tell me about her medication that is continued or prescribed to her on September 14, 2010.
We continued Lamictal, continued Cogentin, continued Klonopin, continued lithium at that time.
Okay. And so the lithium at that point is there to help with her depressed symptoms.
Correct.
Okay. It seems to be improving some.
Correct.
But still continuing with mild depression.
Yes.
Okay. When is the next time that you see Ms. Schenecker?
According to the medical record, September 28th.
Okay. How long did you meet with her on that day?
At least 20 minutes.
How is she doing on that day at the end of September as far as her depressive symptoms?
Continued mild symptoms of depression, but an improvement in energy and continued mild irritability.
Okay. When you talk to her as far as her mental status exam, what does she tell you on that day, on September 28th, about her mood?
Her mood was sad.
Did she expound on that at all?
I don't recall.
Okay. There's no indication as to what she would have said along with that?
It's not indicated in the medical record here.
So her lithium is continuing at that point. Is there an indication that they've reached therapeutic levels on that date, on September 28, 2010?
On that date, I don't believe labs were drawn, but I did see some labs that were done on September 10th or September 24th, possibly. Let me see. There are some labs that were scanned into the electronic medical record.
Do you have an indication on your progress notes of September 28, 2010, if there were labs conducted on September 13, 2010?
Oh, yes.
Okay. And in your assessment, what is your indication about her depressive symptoms and her lithium?
That she continued to have depressive symptoms despite lithium being at a therapeutic level.
Okay. The depressive symptoms that she's having at that time, how do you qualify them in your assessment?
Mild to moderate.
What do you do as far as her medication on that day, on September 28, 2010?
Decrease cogentin.
Why are you decreasing cogentin at that point?
Cogentin at times can be associated with sedation, and so that can possibly be responsible for low energy level.
Okay. So are you, at that point, and throughout your treatment of Ms. Schenecker, are you changing or altering medications to try to get her to the right mood?
Or that's correct. Or treat potential side effects of medications.
Okay. The tardive dyskinesia in her case specifically.
Well, cogentin being at the minimum dose that will help with those symptoms while not causing secondary like sedation or decrease in energy.
Okay. What do you do with the Lamictal?
Lamictal begins a slow taper. The thought process being she is now on 2 mood stabilizing medications, and the potential, as you add medications, the potential for side effects increases or interactions increases. So getting rid of medications sometimes can be just as effective on symptoms as adding medications.
Okay. What are you trying to do by slowing down or tapering off the Lamictal at that time?
Again, I think it goes back to reducing the number of medications in order to prevent potential interactions and side effects.
When you, what do you do as far as the Klonopin and the lithium?
We continued it.
Okay. Is there any alteration to those two medications that are given to Ms. Schenecker?
No, not at that time.
Tell me about the next visit that you have, which I believe is October 12th, 2010.
So at that time, she displays improved depressive symptoms after kind of being away from stressors and being on vacation.
Okay. So she indicated to you that she went and visited a friend, and when she came back, her mood was better?
That's correct.
Okay. How do you qualify her depressive symptoms at that juncture?
It's qualified in the electronic medical record as improved.
Are they still there and improved, or?
Yes.
Okay.
Yep.
What do you do as far as her medication on that day, on October 12, 2010?
We continue the Cogentin, continue clonazepam or the Klonopin, continued lithium, and we restarted the lamotrigine. We started increasing again we reversed the taper, basically.
Okay, when you say lamotrigine, is that also another word for Lamictal?
Correct.
Okay.
Lamictal is the trade and lamotrigine is generic name.
So you can refer to those two things interchangeably.
Correct.
So before you were decreasing the Lamictal, and now you're starting it back up?
That's correct.
Okay. The next time you see her is when? I'm sorry, of September 28, 2010. If there were labs conducted on September 13, 2010?
Oh, yes.
Okay. And in your assessment, what is your indication about her depressive symptoms and her lithium?
That she continued to have depressive symptoms despite lithium being at a therapeutic level.
Okay. The depressive symptoms that she's having at that time, how do you qualify them in your assessment?
Mild to moderate.
What do you do as far as her medication on that day, on September 28, 2010?
Decrease Cogentin.
Why are you decreasing Cogentin at that point?
Cogentin at times can be associated with sedation, and so that can possibly be responsible for low energy level.
Okay. So are you, at that point, and throughout your treatment of Ms. Schenecker, are you changing or altering medications to try to get her to the right mood?
Or that's correct. Or treat potential side effects of medications.
Okay. The tardive dyskinesia in her case specifically.
Well, Cogentin being at the minimum dose that will help with those symptoms while not causing secondary like sedation or decrease in energy.
Okay. What do you do with the Lamictal?
Lamictal begins a slow taper. The thought process being she is now on 2 mood stabilizing medications, and the potential as you add medications the potential for side effects increases or interactions increases. So getting rid of medications sometimes can be just as effective on symptoms as adding medications.
What are you trying to do by slowing down or tapering off the Lamictal at that time?
Again, I think it goes back to reducing the number of medications in order to prevent potential interactions and side effects.
When you, what do you do as far as the Klonopin and the lithium?
We continued it.
Okay. Is there any alteration to those two medications that are given to Ms. Schenecker?
No, not at that time.
Tell me about the next visit that you have, which I believe is October 12th, 2010.
So at that time, she displays improved depressive symptoms after kind of being away from stressors and being on vacation.
Okay. So she indicated to you that she went and visited a friend, and when she came back, her mood was better?
That's correct.
Okay. How do you qualify her depressive symptoms at that juncture?
It's qualified in the electronic medical record as improved.
Are they still there and improved, or?
Yes.
Okay.
Yep.
What do you do as far as her medication on that day, on October 12, 2010?
We continue the Congentin, continue clonazepam or the Klonopin, continued lithium, and we restarted the lamotrigine. We started increasing again we reversed the taper, basically.
Okay. When you say lamotrigine, is that also another word for Lamictal?
Correct.
Okay.
Lamictal is the trade, and lamotrigine is the generic name.
So you can refer to those two things interchangeably.
Correct.
So before you were decreasing the Lamictal, and now you're starting it back up?
That's correct.
Okay. The next time you see her is when?
Looks like December 3rd, 2010,
Okay.
perhaps after a couple of missed appointments.
Okay. So there's no indication for the month of November that you saw Ms. Schenecker?
Not to my recollection or to the, or indicated in the medical record.
Okay. Is there a reflection that on December 1st, 2010, that Ms. Schenecker was attempting to see you on that day?
December 1st?
Yes.
Looks like, yes.
Okay. Tell me about what happened on December 1st, 2010.
It's indicated that due to a miscommunication, she was to be seen later than she expected, and she was unable to keep her appointment time due to scheduling conflicts.
Okay. And so she ended up coming in on December 3rd?
Yes, that's what's indicated in electronic medical record.
Tell me about how her depressive symptoms are doing on that day.
They continue to be mild to moderate.
Did you have any indication about why Ms. Schenecker did not see you or have any sessions with you in November?
I don't know that it's indicated in this particular note.
Okay. Tell me about the medication that she was continued on or prescribed on December 1st, 2010.
Lamictal, Cogentin.
I'm sorry, let me correct that, December 3rd, 2010, I apologize.
December 3rd, continued Lamictal, continued Cogentin, continued Klonopin, continued lithium, continued Celexa.
Are you changing or altering the dosages at all at that time?
No.
When is the next time that you see Ms. Schenecker?
December 10th.
Yes.
I'm going to show you a demonstrative aid. It's the month of December 2010. Now, the last time that Ms. Schenecker saw you, I believe you indicated was December 3rd of 2010?
That's what's indicated.
Okay, and what day of the week was that?
Friday.
Okay. The next time that she sees you is on what day?
The 10th? Yep.
The
So
10th?
Friday,
Okay, so that's the following Friday, 1 week later?
to my understanding.
Okay. How were her depressive symptoms on December 10th of 2010?
Moderate.
What do you remember about that?
What's indicated in the electronic medical record, the significant thing was she had occasional vague thoughts, vague suicidal ideation without plans or intent.
Okay. What does she tell you, or what are your indications about feelings of helplessness and hopelessness?
She amended to some feelings of helplessness and hopelessness.
What does that indicate to you, that now she's having feelings of helplessness and hopelessness?
That she's having worsening depressive symptoms.
Okay. And this is someone who, according to your records, was having depression since the end of July or the beginning of August?
Prior to that even, I believe.
Okay, so prior to that, she's indicating to you consistently that she is either mild or moderately depressed?
Correct.
Okay. I believe your testimony is the only change in that was when she went on a vacation
That's correct.
to see a friend. Okay.
Well, I think there were fluctuations, but
With the medication, there were a few times that she had improved a little.
I think it's multifactorial,
Okay.
where depending on interpersonal interactions, alcohol use, whether or not she's in rehab or, going through the effects of a car accident. I mean, there's several.
Well, now when you're talking about rehab, when did you find out about the rehab?
I'm not sure exactly when I found out about the rehab, but it's indicated.
Where is it indicated in your notes?
I think it's indicated in December 3rd, but it may have been
Okay.
communication earlier.
All right. So when she comes in to see you on December 10th of 2010, your indication regarding her depressive symptoms are that they're moderate?
On December 10th?
Yes.
That's correct.
And she's having occasional thoughts of suicidal ideation.
So vague suicidal ideation.
Okay. What does that mean?
So vague versus specific. Someone with vague suicidal ideation may say something like, it'd be better if I wasn't around, versus I'm going to kill myself.
Okay.
So specific would be, I am going to end my life, versus vague, which would be, statements where, maybe not wanting to be around or feeling like a burden, those kind of things.
Do you have any quotations as to what she told you that you took as a vague thought of suicidal ideation?
I don't believe so.
What does she tell you as far as her mood?
Down?
Now, on your mental status exam, do you also take note of how someone appears to you? Their hygiene, things of that nature?
Yes.
Okay. And when Ms. Schenecker presented to you, did she ever present to you in a fashion where she appeared to be disheveled?
I don't recall, unfortunately, but not that I remember.
Okay. Her mood was down. What do you have indicated as far as her hygiene on that day?
Good hygiene.
What is your indication as far as the suicide risk assessment, as far as any prior attempts on suicide?
2 prior attempts. Last was about 5 years ago by overdose.
Okay. And is that something that you take into consideration as far as your assessment?
Yes.
And what was your ultimate suicide risk assessment for Ms. Schenecker on December 10th, 2010?
Medium.
What does medium mean?
Medium means not low and not high risk, and so it indicates a medium or moderate risk for suicidal behavior.
What does that mean in layman's terms?
So it means that this person has some risk factors for suicidal behavior.
Do you take into account with that risk the fact that she had been depressed for months prior to December 2010?
Yes. I mean, it's multifactorial, so yeah, absolutely.
On your Axis 4 diagnosis for Ms. Schenecker back on December 10th, 2010, tell me what you have indicated for that diagnosis.
Chronic mental illness, limited insight, limited coping skills, conflict with her daughter, and in partner relational issues.
What does that mean, limited insight?
So limited insight indicates that her awareness of the impact, it could be a lot of different things, but one of the aspects is her awareness of the impact of her mental illness on others, or her awareness of her mental illness and how that affects her could be limited.
Limited coping skills, what does that mean?
So adaptability, so when there is a stress, skills such as resiliency, ability to adapt to change, and deal with feelings or emotions in more of a mature way. That's what that refers to.
When you assess her on December 10, 2010, do you consider Baker Act criteria?
Yes.
Can you explain to the jury what a Baker Act is?
So Baker Act is the state of Florida, the citizens of the state of Florida, through government authorities granting certain designated officials such as law enforcement or mental health professionals such as psychiatrists, licensed clinical mental health therapists, licensed clinical social workers that they have licensed through the state, limited police powers to hold someone against their will and take away their rights to freedom in severe cases of, in severe and specific cases such as very high risk for suicide, so harms to self, harm to others, or neglect for self, where the neglect would lead to imminent risk of harm to them, and some other circumstances based on a mental health condition.
Are you as a psychiatrist able to initiate Baker Act proceedings on a patient?
Yes.
Okay. Are there other types of hospitalization that are outside of Baker Act?
Yes.
And explain those to the jury, those options.
There's a variety of other options, such as partial hospitalization, voluntary hospitalization, intense outpatient, which we're kind of following an intense outpatient program with her, and seeing her more regularly, and other models.
When a patient comes in and they may not meet Baker Act criteria, are you still able to speak to them about going to a hospital?
Yes.
Or speak to their family members about that?
The family member part is limited according to HIPAA
Okay.
regulations.
Can you talk to the jury about HIPAA regulations?
So the Healthcare Portability Act involves protection of medical information, and there's very rare circumstances it can be altered. A judge can, of course, order and subpoena information, but essentially, without the patient's permission, medical records can't be disclosed to anybody else except for specific providers that are directly involved in her care.
Do patients have to sign HIPAA waivers?
That's correct.
Okay. And in this case, did Ms. Schenecker sign a HIPAA waiver for her family to be, or her husband to be consulted about her treatment?
It was requested, but she declined.
Okay. For HIPAA, does that prevent a doctor or psychiatrist from obtaining information from a family member or someone to consider in your treatment of an individual?
No.
Okay, so it doesn't limit your information in, just your information out?
Correct.
Okay. And in this case, did you receive information from Parker Schenecker regarding his observations of Julie Schenecker?
Yes, he emailed me.
Okay. And was that done on several occasions?
Yes.
Okay. When you have a person that you have a good faith belief that they pose a threat, are you able to speak to a family member that could help deal with that threat even without a HIPAA waiver?
Yes, under Terrasoft, if I believe, and it's not a threat to herself, which was indicated here, but the threat to others. So if she said, I want to kill this person, then I can notify under Terrasoft the person and the authorities. But the threat to harm herself is not covered under that case law.
So you're not able to share any kind of information without a HIPAA waiver to someone who's potentially suicidal to their family members?
Not without release of information.
Even limited information you are not allowed to share?
That's my understanding.
What medication...
Counsel, before you go ahead, if you both step up. We're going to send you for a lunch break. We'll have everybody back, and we know back means in the courtroom 53A in the usual fashion at 2:00 p.m. As I send you out for this lunch break, I'm going to remind you of those important instructions. We're in the course of trial. You're not to discuss the case among yourselves, not to discuss it with anyone else, not to allow anyone to discuss it with you or in your presence. If anyone intends to say anything to you or in your presence about this case during the break, you tell them you're on the jury, tell them to stop. If they persist, leave them at once. As soon as possible, tell the bailiff who in turn will advise me. I'll remind you this case must be tried based upon the evidence presented in this courtroom, in your presence, in the presence of the attorneys, the defendant, and the judge. You're not to conduct any investigation on your own, not to visit any of the places that may have been described in the evidence, not to read or listen to any reports about the case from any source whatsoever, not to speak at all with attorneys, witnesses, defendant about any subject to deliberations are finished, and not to do any research, gather information about, or communicate about this case or the people or places involved through any means, including electronic devices. We'll see you at 2.
All rise.